second part where I'm really delighted to have Dr. Paresh Malhotra from Imperial College London coming over here. So Paresh is a reader at Imperial College, and at the same time he's a consultant also at the Hammersmith and Charing Cross Hospital. I always forget the second part. So we're delighted to have him here, and he's talking today about diagnosing dementia, PET scans, lumbar punctures, and pitfalls. Over to you, Paresh.
Thank you very much. So thank you all very much for having me. So I just thought I'd start by telling you what I do on a day-to-day, week-to-week basis, and then go into what I'm going to talk about. So I'm 50%, 50%. So my 50% of research is understanding how thinking, particularly memory, attention, and concentration, are affected by diseases of the brain. I started off mainly in stroke and seeing how that affected attention, and then over the last 10 years or so I've done more work in dementia. And of course, well, I hope of course, part of this is trying to develop new treatments for people who have thinking problems and attention problems. And then I also am a clinician, so I'm a consultant, and every Monday morning I do what is called a cognitive neurology or a memory clinic or a dementia clinic, and the work there consists of making a diagnosis in people with possible or suspected dementia or cognitive impairment, and again to start treatments and potentially refer people to appropriate research so that they can take part in that. And what I'm going to talk to you about today, I'm very excited about because it's at the interface between the two. It's where the research meets the clinical work and trying to see how we make a diagnosis and understanding that process and what new techniques have become available in the last 10, 15, 20 years that have changed that process. And I've put pitfalls in the talk on purpose because I know that often when people talk to other researchers or to clinicians or to, I was about to say patients, but people and living with dementia and their families, they're evangelists. And they want to say how good the new technique is and how perfect it is and how brilliant it is, etc., etc. I will try to be as honest with you as I can be about what these tests mean, how we interpret them in clinic, and the pitfalls associated with each of them. None of these things is perfect. A lot of what I say now will not be true in 10 years' time because things will have moved on, but this is how I understand it at the moment. So, what do we do? We've already heard from Robin about diagnoses and what cause dementia. So we have these conditions on the left-hand side, which are really neurodegenerative diseases, diseases that cause the brain to shrink. Alzheimer's disease, frontotemporal dementia, what was described as frontotemporal lobar degeneration in the last talk, cerebrovascular disease and stroke, Lewy body disease, Huntington's disease, and then CJD, which we've heard a lot about in the news 20, 30 years ago. Then all these other things on the right can also mimic dementia. So if someone has enough head injuries, some people with HIV or AIDS or other infections, people with autoimmune disease of the brain, all of these things can also cause cognitive impairment and dementia and need to be ruled out in the clinic before we start saying this is a brain shrinking condition, this is a neurodegenerative disease. And really, Alzheimer's disease is the most common of these, the most common neurodegenerative condition that causes dementia. And that's what we're often trying to rule in or rule out. It's the most frequently occurring and most likely condition to be causing dementia in old age and in younger people. And we do this in a very, very old-fashioned way in the majority of cases. We talk to the patient, and then we talk to their spouse, their carer, their family and friends. And what we're trying to find out is there anything that this person used to do that they cannot do now because their thinking is affected? That's my approach, and that's as simple as it gets. So what could they do before that they cannot do now? In someone who's still working, can they still do everything at work? If it's someone who's picking up their grandchildren from school, are they still able to do that? Can they still follow the person around? Can they remember that it's time to go and pick them up? Have they forgotten at all? It's these things. It's about the individual and what they do. So it's much more personalized than doing a scan or a blood test. It's about knowing that person, knowing what they could do before, and really it's critical that we speak to a family member. So if someone comes on their own to clinic, often one of the most important things that I'll do is take the phone number of their family member, whether it's their partner or someone else, and have a 15-20-minute conversation with them to ask what's been happening, what's changed, and that change is critical. And then we have an examination, perhaps some memory tests, a neurological examination, see if there's any weakness, any signs of stroke, any problems with vision or eye movements. And then last, we come to the fancy investigations, which is what everybody likes to talk about. So these are the add-on, the thing that comes on the end. They're not the real presentation or the key to making the diagnosis. They're something that help us, and that should always be remembered, that it's a tool. It's not the be-all and end-all. And in straightforward cases, the imaging can help confirm the clinical suspicion. So if we think it's Alzheimer's disease, it'll help us confirm that. But it can also rule out other conditions that could be causing these symptoms. And so this is a CT scan, which is basically a technique using X-rays. So we get a slice through the brain, and it's a slice like this at the top of someone's head. This is all brain tissue. Can you see that all right? Can you make out the slide? Just about. Can you see that white rim there? So this is the very bright bit is the skull, and can you see that white rim there between brain and skull? Can everyone see that? So that's blood. So this person, thank you very much. This person has had a brain hemorrhage, and it's that hemorrhage that's causing their cognitive problems. So rather than this being a scan to tell us that someone has Alzheimer's or not, it's something we can do rapidly, and we see that the patient has a hemorrhage, and then we can deal with this with surgery or not, depending on whether it's required. But in this case, the imaging has ruled out other conditions. We were thinking it might be a neurodegenerative condition, but it actually turned out to be a hemorrhage. So what do we do to diagnose? So the clinical assessment is what I mentioned. So the sort of thing we can do in clinic is something like this, where there are tests of memory, attention, what we call executive function and language, and then you get a score out of 30. This is the Montreal cognitive assessment, and the most famous person to have taken this is this man here, who says that he got full marks, and I'm not going to make any further comment about that whatsoever. But this is something that can be done in clinic. So the person doesn't need to come back to the hospital. It's something that takes really 10 or 15 minutes, no more. But it's a crude tool, to say it's a crude business anyway. What we can do is something much more thorough. So we can invite someone back, and they can spend 2 or 3 hours doing memory tests, attentional tests, cognitive tests. And that's formal neuropsychological testing. But it does require someone to come back. And then we can do imaging, in particular MRI scans. And until, 15 or 20 years ago, the other key thing was time. So we'd wait. And often, still really sometimes, at the end of a clinic appointment, we'd say, well, let's see. I'll see you again in 6 months. I'll see you again in 9 months. I'll see you again in 12 months. I'll see you again when I've got another appointment. And then we'll see if things have changed. And time is very, very important. And one of the things that I'm going to go through again and again in this talk is the importance of time and more than one measurement at more than one time point. So having a single snapshot, whether it's neuropsychology or an MRI scan, is not always enough. More recently, we can take fluid from someone's spine, or we can do types of PET scan, and that gives us a better idea of the underlying cause of someone's dementia or cognitive impairment. So, just to go through the things we've discussed. Neuropsychology is often pen and paper testing. It can involve different domains of cognition, so memory, attention, decision making, and going through all these. It's not too expensive, but it is time consuming. It can be done in someone's home. It doesn't have to be done in a scanner, but it takes ages. It's quite a long time. Also, it's very much affected by culture and education. So you have to have norms for each test. What should that person be getting, given that they were educated for this many years and they've been brought up with this as their first language? So there's lots of comparisons that you have to make. You don't get a straightforward, straight-out answer. It doesn't always tell us what the underlying condition is, tells us that someone has problems. So again, it's a single snapshot in time. It can never be totally definitive. MRI scans. So these are the things that we show pictures of all the time. Some people will read reports of MRI scans. Some people will look at pictures of MRI scans. But what's important to know, and this is what I say to people in clinic, and you're welcome to pick me up on it after we finish, but our brains are like our skin. So our brains do not look the same at 50 as they did at 20 as they did at 10. It's the same. We pick up blemishes. The structure of our skin is not the same. And we can see the same when we look at brain scans. And also, to be honest, if someone has smoked 30 a day and drunk a bottle of vodka a day, you can often see that in their skin. And the same thing occurs with the brain as well. You can see those changes when you look at brain scans. So it's not a clear-cut thing that the brain has shrunk or it hasn't, because you might have all these other factors come into play. So this is a 25-year-old's brain, and when people talk about Alzheimer's normally, they talk about these structures here, the hippocampi, which are related to memory, and in typical Alzheimer's, in a typical scan, we'd expect them to shrink. But remember, this is a 25-year-old's brain, so this is the white matter, which is mainly made up of fibers, like cables taken from one nerve cell to another. This is the grey matter. These black areas are the cerebrospinal fluid, which bathes the brain. And this is a 67-year-old's brain. And I think you should all be able to see that there's a bit more fluid in the 67-year-old's brain bathing it. And the brain is smaller, its shape is slightly different, and the hippocampi are a bit smaller as well. Can you all see that there's a subtle difference between the 67-year-old's brain and the 25-year-old? It's not massive, but it has changed over time. It's not quite the same thing. And then if we look at a 67-year-old with Alzheimer's, the gaps between where the fluid are much bigger. There's been degeneration so that there's more fluid and less brain throughout the brain here, and the hippocampi are much, much smaller. Can you all see that? So it's not that Alzheimer's is an extension of aging, but what I'm trying to say is the brain changes with aging, and it changes in different ways and more with these neurodegenerative conditions, these brain shrinking conditions. And that's important to keep in mind. None of these things is quite as absolute as we might say it is. So, MRI scans are high resolution. You could see how beautiful those pictures of the brain were. They can show us the volume of structures like the hippocampus. So if you do MRIs year after year, you can measure in milliliters the volume going down in someone who has Alzheimer's. You can see that there's neurodegeneration. But it doesn't tell us what's causing the problem. Robin mentioned those two substances, those two proteins, amyloid and tau. And MRI scans don't show us those things. Also, the MRI scans don't always show us the typical changes. If patients are younger, or if they have a different sort of presentation, if they don't have the typical memory loss that we see in typical Alzheimer's disease, the MRI scan doesn't change in typical ways. And as I've said before now, it's a single snapshot of a process that takes place over time. So one MRI scan on its own doesn't always give the answer. And if it doesn't fit with the clinical picture, with how someone has been, then you should be very wary of the scan rather than of the patient's story or their family's story. Then this is another type of test called a PET scan. So I'm going to talk about PET scans more later, but I wanted to tell you about this type of PET scan first. So this is what's called an FDG PET scan. But all that means really is it's using glucose, and it's looking at brain metabolism and which bits of brain are active and which bits aren't. And you can use this type of PET scan to look at the whole body, because if you inject this substance, FDG, fluorodeoxyglucose, it's a radioactive chemical that's very similar to glucose, and it will go to the parts of the body or brain that are very metabolically active. So if you're looking at the rest of the body, you might be looking for something like cancer, a hidden cancer, which is very active, and you can see the activity on the scan, whether it's in the stomach or in the chest or wherever, and standard scans might not pick that up. But if we use it in the brain, it shows us bits of brain that aren't active, that aren't as active as they should be. And this is very sensitive for early neurodegenerative disease. So before there's any shrinking, parts of the brain start to become underactive. And we can see that in PET scans like this by looking at metabolism. So looking at which bits are taking up glucose at high speed and which bits aren't. But again, this doesn't tell us about the proteins that are causing the problem. It doesn't tell us about the hallmark proteins that cause Alzheimer's disease or any of the other conditions I mentioned. And I've sort of skirted around the fact, but just to stress again, these scans are, on the whole, interpreted by specialists who give an opinion. And that opinion is based on their interpretation of the scan. If there's a bit of shrinkage, if these changes aren't as obvious, they have to hedge their bets slightly. It's not always a clear-cut, yes, this is abnormal, no, this isn't. It's much more of a, there could be some abnormality here, but not sure, maybe scan again in a year's time. So all these things are an opinion, and that's not to denigrate my colleagues, it's just to let you know that these aren't numbers, these aren't yeses and nos, but much more nuanced statements about what can be seen or what can't on the scan. So, I've mentioned those proteins, amyloid and tau, more than once. So this is amyloid, which accumulates outside cells in plaques that are about the thickness of a sheet of paper. And this is the hallmark of Alzheimer's disease, along with these tau tangles, which are within cells, within neurons. And from the evidence that we have to date, it appears that amyloid comes first in the brain and then is followed by tau. So if we can detect these things in people who are alive, then we should be able to have a surrogate for what happens when we look at tissue under the microscope after people have died. So Robin mentioned that the only way we can diagnose absolutely Alzheimer's disease is with post-mortem tissue, but if we can have an indication that these things are there in life, then at least that gets us closer. And so the first of these things is doing a lumbar puncture. So when I first gave this talk, my wife told me, you can't put that picture in, and you can't show this. And I said that I'll try, and I've been all right so far, but for anybody who's offended by it, I apologize. But I wanted to show what it actually involves, because otherwise people talk about spinal taps, they talk about lumbar punctures, and they don't actually necessarily know what it means. And to be honest, also, if you've had it, you don't want to know what it means, because it's in your back and you can't see it. So it's basically putting a needle in at the base of the spine. It's below where the spinal cord ends, so you're putting the needle into a bag of fluid, and drops of clear fluid that supposed to look like gin, but to me just look like water, drop into a tube, and it's taken off for analysis. It's uncomfortable. The worst bit, in my experience when I've been doing them, is when patients have the local anesthetic put in. Having one done is much worse in casualty, in an emergency, when someone's got suspected meningitis, than it is when it's all being done in a lot more calm fashion in a unit where they're done every day for diagnostic reasons. So, and it gives us an idea of what's going on around the brain, because that fluid at the base of the spine is the same fluid that is bathing the brain and that you saw in those black areas on the MRI scan. It's the same stuff. So it's telling us about what's going on around the brain, and when we analyze it, it gives us an idea of whether someone has amyloid deposition in their brain. So it's a surrogate for seeing amyloid and tau and for post-mortem examination. And a very good one. And it's been used clinically for at least 15 to 20 years now. But of course, it's not a very nice thing to have a needle put in you. It doesn't sound very nice. And when I bring it up, even though I say, look, it's okay on the whole, it's still uncomfortable. Anytime you put a needle into someone, it can result in infection or local bleeding or complications. And a fifth of people who have one roughly get a headache for a couple of days afterwards as well. So it's by no means perfect. And also, in our experience, if you don't have the lab in your hospital where you work, the process of putting it into the right tube, getting it at the right temperature, transporting it to the place where it needs to be analysed can result in inaccuracies. And if you've gone to the trouble of having this done to yourself, if you've gone to the trouble of sort of helping your relative go through this, and if you've gone to the trouble of arranging it and persuading a patient to do it so you'll get a diagnosis, and then you get an inaccurate result after 2 months, then it's very distressing and upsetting. So whenever this is done, it has to be done properly in a centre which does them regularly, and we can rely on the results. So this processing and assay stability is critical. So when it's done properly, it's very reliable and very helpful, but if it's done haphazardly at all, it can be very distressing and upsetting, and it's understandably enraging for patients and their carers to hear, oh, we didn't get a proper result, would you like to have it done again? And then we come on to amyloid PET imaging, which I'll talk a little bit more about. So I've told you about glucose PET imaging, which is about metabolism. And so these are FDG PETs, the glucose PETs that I mentioned earlier. But around 15 years ago in Pittsburgh, some researchers developed a chemical, a radioactive one, called PIB, Pittsburgh compound B, that would stick to the amyloid in someone's brain. So you could inject it after producing it, and then you could wait a while, and then you could do a scan, and then you could visualize this protein that causes Alzheimer's disease. So this is what I'm going to refer to as amyloid PET throughout. And at the time when this was done, 2004, these compounds could only be made in cyclotrons. They were very unstable compounds that could only be made in specialist facilities. And so you could only really do them in research centres. Since then, companies have made much more stable carbon-based versions rather than the fluorine that can be transported to centres, for instance, throughout the UK. So this sort of scan can be done on a much more routine basis without the need for that cyclotron. And it's been reliably shown over and over again that the substance sticks to amyloid reliably, and it gives us an idea of when there are Alzheimer's changes in the brain that are the ones that we'd see if we were to do a microscopic examination of the brain tissue. So that's amyloid PET imaging. And it's taken off in research. In research throughout the world, these are just a few of the studies that I'd spent a minute and a half looking for and put them up there. And in research, it's being used to see when amyloid occurs, how it affects what happens to someone, and we think that from what Robin was saying as well, maybe 10, 15 years before someone has symptoms, we start to see amyloid in their brains, and that can be seen with these PET scans. So more and more research is being done to see how it influences cognitive impairment, when atrophy starts, and also, of course, if we treat these individuals, whether it stops the progression of Alzheimer's changes and cognitive problems. And these are some of those studies. But I'm going to talk to you about clinical amyloid PET imaging. And so this is Charing Cross Hospital. In almost 20 years of working there on and off, this is the most glamorous photo that I could take of it. So I apologize, but that's as good as it's going to look, I'm afraid. And up till 2013, I think, we would use the combination that I described earlier. Of course, we'd stress the history, we'd do an examination, we'd do that brief cognitive testing I described to you, but then we'd request an MRI scan in everyone, we'd do neuropsychological testing for 2 or 3 hours, can I get that? Yeah, there. And then sometimes when necessary, we'd also organise a lumbar puncture with all the attendant failings that I described to you as well. And then in 2013, my colleagues, Adam Waldman, who's now a professor in Edinburgh, Richard Perry, who's still a consultant with me now, and Zani Wynn, who's a nuclear medicine physician and radiologist, and myself, we started to have the availability to do amyloid PET scans on the NHS. So our trust would pay for them, and we would request them. Now, this is not just that simple as I'd sit in clinic and say amyloid PET for each patient I saw. What we have is a set of internationally approved appropriate use criteria. So the patients that have these scans have to be either younger than usual, or they have to have an atypical presentation, something uncommon, or there may be some other factor, some other condition that makes it difficult to interpret whether or not they may have Alzheimer's disease. So let's say these might be people who are in their 50s, 60s, 40s, or they may have predominantly visual problems that affect the back of the brain rather than memory, or they may have another condition. They may have something like multiple sclerosis. They may have had a brain tumor which required radiation therapy. And each of these things makes it difficult to determine what exactly is causing their cognitive problems and could it be Alzheimer's disease. And so we started to have a meeting every fortnight, which still happens every other Friday, where we discuss individual patients and decide whether or not they should go ahead for an amyloid PET scan. And these are the sorts of pictures you see in press releases. I myself have approved a press release with a picture like this discussing amyloid PET imaging. They're very bright, they're very exciting. Everybody goes, woo, aren't these scans nice? This is the reality, and this is what my colleagues look at and have to interpret. And you can see that it's not quite as clear-cut as it might be. So this is a positive scan. It is someone who has the changes of Alzheimer's disease. And the reason it is a positive scan is that you can't really make out those fibers that are next to the fluid-filled ventricles. You can't make them out spreading. It seems a mix of greys, really, but there's no clear-cut spreading fibers going out from the ventricles. Can you see that? It's quite tricky. You might require the eye of faith a little bit. Whereas this is a negative scan. This is someone who doesn't have Alzheimer's changes. And here you can see the shape of the so-called white matter that's black on the scan, confusingly. But can you see how the shape is delineated there? It's clearer to make out, whereas there it's not. So that's how the scan is interpreted. It's not perfect, it's not easy, and these are exemplar scans that are very clear. So the ones that are tricky are much harder to differentiate than this. And just go through, the positive scan has been likened to a tree in bloom because you can't make out the individual branches of the white matter, whereas the negative scan, the one without Alzheimer's changes, is like a branching tree where there are no leaves. So you can see the individual branches, whether you're looking at a slice like this, here and here, or you're looking at a slice like this, in the same plane as the face. Here you can see the branches, here you can't. So that's the sort of picture that my colleagues look at and that we all look at when we're interpreting the scans. And I don't want to go, if I was giving this presentation to lots and lots of clinicians and saying why it's useful, I'd go through case after case after case. But I just want to give you an indication of where it might be useful and what might occur when we do it. So this is someone who'd been diagnosed with Alzheimer's disease and came to our clinic looking for a second opinion, with the history that suggested that there hadn't been much decline, and with this person's function, that they could still do a lot of the things that they used to do in daily life. We thought with the patient and their carers that it might be useful to get this scan and see if the diagnosis of Alzheimer's disease was correct. And when we did the scan, it was negative, providing strong evidence that there was no underlying Alzheimer's disease. And as you can imagine, making a big difference to this patient's life, to their prognosis, and to how they felt about life going forward. So that's a negative scan. This is an individual who had had memory problems and thinking problems for 7 years. That's how long ago they'd first gone to a clinic. They'd initially been diagnosed with depression, treated with antidepressants. Then they'd been told that there probably wasn't much wrong, but they just were finding things more and more difficult year after year. But they were young. They were under 65. And we went on to, again, after discussing the scan with them and their relatives, request one, and they had a positive scan, confirming the diagnosis of Alzheimer's that we'd suspected. So that was what was causing their problems, rather than the depression that had been suspected. And we were able to give this person a diagnosis and explain what was causing these problems to her family. And so we went on, this is 2 years ago now, to look at the impact of what we were doing. So we've done more amyloid PET scans than anywhere else in the country. We're one of the leading units in Europe for this sort of thing in clinical practice, so not in research. No consent forms required, no added research expenditure required. This is about daily or weekly or monthly clinical practice. And what's important is out of our first 100 patients, 23 had a positive amyloid scan, but someone in the previous year or two had said their MRI scan was normal. Okay? So MRI scans aren't perfect by any means. 12 patients who had a report of their MRI scan saying that there were changes suggestive of Alzheimer's disease had a negative amyloid PET scan. And in 42, so less than half, but quite a lot, it changed the management of the patient. So either they started standard Alzheimer's drugs, or they went into appropriate trials, or they stopped drugs and stopped management for Alzheimer's disease. So it did change what happened for people. It wasn't just a question of us being able to say, oh, it's something different, and then they walk away. What happened to them, what they were able to take, what they were able to take part in, changed because of what we did. And so we've now scanned nearly 400 patients, and we've got funding to actually do blinded MRI analysis. So ask our radiologists to look at the MRI scans without knowing what the answer of the amyloid PET scan is, and then just tell us, what do you think, and compare the two. We'll also go to all the patients whom we've scanned before, and if possible, find out exactly what's happened to them and see and check that everything is consistent with our results so far. And then we'll get a formal database going forward so we can interrogate how useful this is. And really, I'm wary of saying this, but it is important, how cost effective it is. Does it make a difference? Is it worth it to be spending the NHS's money on tests like these? And should it be used in a much more widespread fashion, or limited to very specialist centres as it is now? And our results so far suggest that the scans reduce time to diagnosis and reduce the number of tests we need to do, but we do need to work out how much it should be used in the real world. And the current NICE guidelines that we got, as neurologists, we got the chance to look at these, I can't remember, a few months ago, and there was nothing about amyloid PET in them. There was a bit about lumbar puncture, but very little. So at least the next set, if we have a data set that tells us about cost effectiveness, about time to diagnosis, about change to management in the NHS without any research involvement, then it makes a difference, and it'll make a difference to NICE guidelines going forward. Now, I'm very proud of our study with our 100 patients, but of course other places do things bigger and better. So in the United States over the last few years, they've done a study with around 10,000 patients across the country. It is a research study where physicians were given the opportunity to refer their patients for amyloid PET scanning if they fitted those criteria that I mentioned to you before. And even in this much larger scale, you can see that the changes are not that different, except that they're even bigger. So management changed in 60% of people with mild cognitive impairment, where memory mainly was affected, and 63% of patients with dementia. And they were the same sort of management changes: drug therapy, counselling about prognosis, and also referral to trials and future planning. So even on that larger scale, we can see that it does affect what happens to people and their families. But I said I'd try to be honest at the start of the talk, so I will continue to, I hope. It's expensive. It's at least £1,000. But you may say, if we have to wait for another couple of years to get a diagnosis, if someone's got a wrong diagnosis, it should be worth that. It'll probably get cheaper. It's not something that should be used on its own. We're using it in conjunction with seeing a patient, spending time with them, the other investigations, and working out what's wrong. If these were just suddenly thrown out at everyone with suspected cognitive impairment, especially as people get older, it starts to get, what we do is start to pick up sort of incidental Alzheimer's, and it may not be the actual cause of someone's problems. And like the MRI scans, they're not always easy to interpret. So it's not just a yes or no. Those ones I showed you were relatively clear-cut, but there are some scans that it's not so clear-cut, and it requires a little more thought, patience, and even then, you may not be able to say definitively one way or the other whether it's positive or negative. So, I've talked about amyloid PET, I've talked about what we do now. I just wanted to say a bit more about the future. As I said, in 10 years' time, everything will be different because things seem to change that fast. I spoke about two proteins, and so did Robin beforehand. There's amyloid outside the cells, the plaques, And then there's tau tangles within the cells as well. And of course, people have developed tau tracers that stick to tau in the brain. And that tells us something slightly different. It tells us that amyloid seems to come first, as I mentioned earlier, but tau seems to be the thing that relates to symptoms much better. So amyloid seems to be widespread throughout the brain, but it's the tau that seems to be linked to those areas that are underactive metabolically, that I showed you that took up less glucose. And it's the tau that seems to link directly to symptoms. So if there's a language problem on the left side of the brain, there seems to be more tau on the left side of the brain. If there's a visual problem at the back of the brain, there seems to be more tau at the back of the brain, whereas the amyloid is much more widespread and not so localized. So it looks like tau, which comes after amyloid, is more related to symptom onset and symptom constellation, what syndrome someone has. So although it may not be used as much diagnostically, it will tell us far more about the process of how people develop thinking problems and what thinking problems those people have. And this is from this week, I'm proud to say, that this is research showing that blood tests are getting increasingly good at telling us whether someone has risk for Alzheimer's disease. And very, very good indeed if you combine them with blood tests for genetic testing. So if you do blood tests looking at amyloid-related proteins and brain degeneration-related proteins, just from a simple blood test, you can have a better idea of whether someone's likely to have underlying Alzheimer's disease or not. It's very unlikely that these will be used on their own, but they could be used as screening before someone goes on to have all the other tests that I mentioned. So although I'm telling you about amyloid PET now as if it's the next big thing, it's wonderful, etc., but in 5 or 10 years' time, I fully expect that blood tests will come before that and will inform our decision about whether to go on to do an amyloid PET, which is associated with radiation and risk from radiation, whereas blood tests, of course, are not. So things are constantly changing, and it's worth keeping that in mind too. Right. I couldn't find, I tried to make a picture of this, and then I found this on the internet. This is apparently a scanner in Japan, which is meant to make children feel better about having a scan. I'll leave you to decide whether or not you'd feel like that. But there are elephants in the room. There are a couple of them. So this is problematic, but it's becoming clearer as well. As we get older, the likelihood of having more than one disease gets greater and greater. If you look at the brain tissue of people who die when they're older, they often have more than just Alzheimer's disease changes. They may have the changes we see associated with Parkinson's type diseases, so-called Lewy body dementia, frontotemporal dementia, and vascular disease as well. All these things can coexist in individuals in varying combinations. So there's me here saying, oh yes, we can diagnose Alzheimer's disease, we can do this and do that. But life's never that simple, and many people are affected by more than one thing. So at the moment, what we can do is we can talk about what their predominant problem is, but it's likely that people will need tailored regimes of treatments, if we can ever find them, to deal with this multiple problems that they may have. And this is the big elephant in the room. So when I give this talk, sometimes in clinic, people say, why bother if there's no treatment that can stop this or reverse this? And as you can see, as you see in the news, the big trials that we all hope for so much, which have mainly focused on getting rid of amyloid, and some of them, with our type of PET scan, have shown that you can reduce the amount of amyloid in the brain, make no effect on cognition, on thinking, or any effect on quality of life. So nothing's worked yet. So why do you want to bother making a diagnosis? What difference does it make? And that nihilism is there in the clinic and outside Alzheimer's research in general. But the answer is knowledge. It's knowledge for the patients, their relatives, their carers. It's knowledge to put the right people into the right trials. And I think if you remember the story of that person who's gone for 7 years without a diagnosis and who'd been told that they had depression, then one problem, couldn't get any benefits, couldn't get any help, etc. The knowledge of having the disease is not a small thing. It's a very important thing to know what the problem is and to know that a neurodegenerative condition is there. And I'll be happy to discuss that with everybody afterwards. But I think at the moment it's critical, and it's critical in helping us find new treatments. And without it, we'd be completely lost. So that's all I wanted to talk about, and that's how I wanted to end. This is a list of the people that fund this sort of work and related work. These are my colleagues to prove that it's actually true. These are the people who sit in with me on a Friday morning discussing those scans and patients and making a decision. And these are the other people who've helped with this work. And thank you very much.
Excellent, thank you very much, Paresh. So, you have the opportunity for questions, and again we have 2 roving mics, so if you want to lift your hand, if you want to ask a question, please go ahead. Oh yes, we have one, fantastic.
Hello, thank you very much. With my very limited understanding of the subject you just talked about, I wanted to know, were you actually saying that MRI scans are pretty much useless in this?
I didn't want to say anything was pretty much useless. I said that I think they have to be, first of all, they should only be looked at in the context of the individual. So you should be thinking about the person in front of you. If the MRI scan fits with the clinical history and presentation, then it's very useful. If it doesn't fit with that person's story and what's happened to them and what their relatives say about them, I tend to trust the story of the patient and their relatives and either do a repeat MRI or think, is there another reason for someone having MRI changes like that? Because an MRI is a single snapshot at a single moment. So I don't think they're by no means useless. I request an MRI scan on almost every patient I see in the clinic, but I just wanted to be clear that they're not perfect, I think is the best way I can put it. Is that all right? Yeah.
Yes, please.
Hello. Thank you very much. It's very, very interesting. You noticed, you mentioned that the scans that were available required great interpretation by trained clinicians. Do you know if there's any move afoot to bring AI into these machines that will sort of hopefully to improve what's going on?
Yes, so there absolutely there is. And I'm sure Michael will agree that every time we see a new grant proposal or any sort of proposal at the moment, it's machine learning and AI to look at imaging. And the results so far suggest that, we were talking about MRI scans just now and whether they were useless or not, that if you use AI to look at, hundreds of features within a scan, they can provide further information as well. But again, keeping in mind the context of the patient, etc. But yes, very much so.
Thank you for a lovely talk. I'm just wondering, in your experience, the findings on PET scan on people or patients with CBD, PSP, and Parkinson's disease, is any substantial difference? Or
do you mean amyloid? So amyloid PET scans or any PET scans?
Any PET scans.
Any PET scans. Yeah. So we use the FDG PET scans quite a bit to look for under-metabolism in all those groups. So depending on what technology is available in any clinic and everybody's experience with that technology, they have a slightly different algorithm or route to where they get, but often, certainly in our practice, in all those 3 groups, unless the clinical picture is absolutely typical and the MRI scan is absolutely typical as well, we may go on to do an FDG PET scan to look at areas of reduced metabolism in those individuals.
Thank you.
Shy, give Isaac something to do on that side. thing is we always talk about, you know, when does a patient become a patient? So, what's your opinion on screening people potentially? Is this something which should be done, and what would you use, or how useful is this? And
so I think it's very important that we understand the disease process by using these scans on a research basis. The majority of those research projects, as you know, don't tell people what those scan results are because we don't really know what they mean in well people. And until we have a treatment that works, screening doesn't seem to make sense. But although there's failure after failure after failure, at some point a treatment will work, and then it will be important to have a system in place so that the people who need that treatment are treated fairly, equally, and at the right time. So it will happen at some point, hopefully sooner rather than later.
do you have any other questions for Paresh? No? Well, then let's just thank him again quickly. Thank you so much. And before you head off, I just want to give you so first of all, thank you very much again for coming to our event, which is fantastic. Don't forget the feedback forms. We will have people at the exits who will collect them. Also, don't forget to validate your car token. Very important at the desk, so you don't have to pay for your parking. So that's really good. Just saying, the next open forum, so our smaller meeting, will be in September. The date is not yet confirmed because the university doesn't release the rooms until July, unfortunately, so we can't decide on the actual. But we have Professor David Wright from the School of Pharmacy, and he's an expert in what's called polypharmacy. So people taking multiple medication, and we know, of course, that loads of older people take multiple medications, and he has done a lot of research in this. So we will have, he has particularly looking at putting pharmacists who can prescribe into care homes, how medicines are managed. Is it a good idea? He will talk about that in September. And thank you again for coming, and please come back, and thank you again for our speakers. Thank you.